Hello and welcome to today's PAL teaching session. We'll be discussing a number of Year 3 endocrinology topics, including the HPA axis, Cushing syndrome, and adrenal insufficiency. So we'll first start by revising the hypothalamic-pituitary axis. This plays a key role in the body's maintenance of homeostasis and also regulates a number of endocrine organs, including the thyroid gland and adrenal gland. The HPA axis also generates the fundamental endocrine response to stress through secretion of the hormone cortisol. The pituitary gland itself has two distinct portions. These are both functionally and embryologically different in their origins. So the anterior pituitary communicates with the hypothalamus via hormones which are secreted into the portal circulation. It secretes ACTH, TSH, prolactin, LH, and FSH. The posterior pituitary can be regarded as an extension of the hypothalamus itself. The hormones ADH and oxytocin are secreted by hypothalamic neurons into posterior pituitary circulation. This figure summarizes the regulation of hormones which are secreted from both the anterior pituitary and the posterior pituitary. It also gives you an idea of the end organs on which they mediate their actions. Just as a note, from now we'll be discussing hormones mostly secreted by the anterior pituitary. The main focus of this lecture will be on growth hormone and prolactin, and we'll later discuss ACTH secretion. So growth hormone acts on the liver to produce insulin-like growth factor. Insulin-like growth factor is the main proxy of growth hormone and acts on peripheral tissues to promote growth, cell survival, and cell regeneration. Growth hormone itself also has an important action in the maintenance of glucose homeostasis. The clinical syndrome associated with growth hormone excess is called acromegaly. Most commonly, this occurs due to a functional pituitary adenoma. Rarer causes are due to pituitary hyperplasia, ectopic growth hormone or growth hormone releasing hormone secretion from tumours also. Acromegaly is associated with syndromes including multiple endocrine neoplasia type 1 and McCune-Albright syndrome. Clinical features associated with acromegaly can be attributed to growth hormone excess, but also mass effects associated with the pressure effects of the pituitary adenoma. So features associated with growth hormone excess include the growth of soft tissues, coarsening of facial appearance, weight gain, joint pain, macroglossia, an increase in hand or glove size, prominent supraorbital ridges, prognathism, and carpal tunnel due to compression of the median nerve as it enters the hand in the carpal tunnel. Other effects include hypertension and diabetes due to growth hormone-mediated peripheral insulin resistance. Mass effects include headache, bitemporal hemianopia due to a compression of the overlying optic chiasm, cranial nerve palsies resulting in ophthalmoplegia, and hyperpituitarism due to compression of surrounding areas of the pituitary that produce hormones, for example, the gonadotropins and TSH. So acromegaly, investigations that we might perform to make a diagnosis of acromegaly include the oral glucose tolerance test. This is diagnostic and the gold standard for diagnosis. Under normal circumstances, growth hormone secretion is inhibited following a glucose load. However, when the test is positive, indicating a diagnosis of acromegaly, the glucose load fails to suppress the growth hormone secretion. I apologise for the background noise. Cardiac assessment in the form of echo and ECG is performed due to these individuals' risk of heart failure. Other important tests include MRI imaging to look for a pituitary lesion, examination of the visual fields, and assessment of other levels of the hormones due to the reasons we've discussed before, and the mass effects. Management. So the mainstay of management is surgical intervention. This is usually through endoscopic transsphenoidal surgery. However, this depends on the location of the lesion itself, and sometimes a transfrontal approach may be necessary. So drug treatment is usually required for residual disease. So this is with somatostatin analogues such as octreotide and more recently pegvisomant. So pegvisomant is used in cases in which there's an inadequate response to surgery and the individual is intolerant to somatostatin analogues due to the expense. So it's a recombinant human growth hormone, and it antagonizes the effects of growth hormone by blocking the growth hormone receptor. So it's also important to mention long-term monitoring for other conditions. So these individuals are monitored for colorectal cancer with colonoscopies every 3 years, and the long-term risk of cardiovascular disease remains high even after the levels of growth hormone are brought back down to normal. So it's important to manage these parameters. So we'll now discuss prolactin. So prolactin is secreted by the anterior pituitary. Under normal circumstances, the secretion is under tonic inhibition by dopamine. So prolactin can be elevated in response to physiological changes, including physiological stimuli, including stress, pregnancy, hypoglycemia, and sexual intercourse. Pathological causes of prolactin rise include iatrogenic causes with medications including atypical antipsychotics and metoclopramide, and pituitary prolactinoma. So pituitary prolactinoma produces extremely raised prolactin levels with levels as high as 500 micromoles. Normal levels are less than 400. And if it's a macroprolactinoma, levels can be even higher than this, between 5,000 and 10,000. Other causes include hypothyroidism and paraneoplastic syndromes, particularly secondary to ovarian cancer, but these won't be discussed further in this lecture. So features of hyperprolactinemia in females include menstrual irregularities, reduced libido and galactorrhea, weight gain and hirsutism. In males, erectile dysfunction, impotence, loss of facial hair, galactorrhea and gynecomastia may occur. And in generally, due to menstrual irregularities presenting quite early, the diagnosis of hyperprolactinemia is usually made more rapidly in females. It may be accompanied by an associated mass effect as well, if due to a pituitary adenoma. Investigations include serum prolactin, a thorough drug history to rule out iatrogenic causes, imaging, including MRI of the pituitary to look for a pituitary lesion, and pregnancy tests in a woman of childbearing age and visual field assessment as well. So management of a pituitary adenoma depends on the size of the pituitary mass. Microprolactinomas, which are less than 10 millimeters in size, as measured on the MRI, are usually managed with medical therapies including bromocriptine and cabergoline. Macroprolactinomas, which are more than 10 millimeters in size, are usually managed with medical therapy and surgery if there are associated visual losses or pressure effects. Bromocriptine is favoured in comparison to cabergoline due to the risk of cardiac fibrosis. If an individual does have to be initiated on cabergoline, they have an echo at both baseline and at 6 months. This is an important part of the monitoring. So the effect of medical therapy not only reduces levels of prolactin by inhibiting prolactin secretion by increasing dopamine levels, but also produces shrinkage of the pituitary mass itself. We'll now briefly discuss hyperpituitarism. So this is the partial or complete deficiency of anterior pituitary hormones. It's a highly variable presentation which depends very much on the underlying cause. So vascular and both traumatic causes, such as pituitary apoplexy, Sheehan syndrome, and pituitary stalk syndrome, can produce an acute presentation of hyperpituitarism in particular. So these are things to be wary of. Clinical features are characterized by the specific hormones that are lost, so they can be complete loss or only certain hormones can be affected. So most commonly, in fact, growth hormone is infected growth hormone is deficient. So due to the somatotroph cells of the anterior pituitary having a very high metabolic rate. So this can present as weight loss with central obesity, dry wrinkly skin, osteoporosis, and reduced exercise tolerance. I won't discuss any of the further, but these are here for you to review. So investigations are basically there to identify and determine the both cause of the endocrine deficit and also the exact endocrine deficit that you're sort of dealing with. So there's non-dynamic testing such as checking estrogen levels, thyroid function levels, LH, FSH, prolactin and IGF levels. There's also dynamic tests such as insulin tolerance test and the short-actin test that focus on assessing the integrity of the adrenal and growth hormone axis. Other tests such as imaging, maybe you may want to perform to look for pituitary lesions, especially if there's high suspicion of this. So the mainstay of treatment is with hormone replacement. An important thing to be aware of is that hydrocortisone should always be initiated before thyroxine. This is because thyroxine can precipitate an adrenal crisis as it causes a spike in the metabolic level. So we'll now discuss Cushing syndrome. So we'll briefly review the adrenal gland. So you can see the zones of the adrenal gland which are presented in this figure here. The adrenal medulla is responsible for catecholamine secretion. So an important way that I try and remember the layers and the hormones that they're responsible for is with the acronym GFR. So glomerulosa produces aldosterone, which is regulated by the renin-angiotensin-aldosterone syndrome. The zona fasciculata is responsible for glucocorticoid secretion. So the main glucocorticoid is cortisol, which is regulated by ACTH. And zona reticularis is responsible for androgen secretion, and this mediates secondary sexual characteristics. So cortisol is the hormone that mediates the endocrine response to stress. It has a number of important essential functions, including glucose homeostasis. It's anti-inflammatory. It mobilizes free fatty acids for energy and promotes bone resorption. At high levels, it can also exert mineralocorticoid effects. It exhibits circadian rhythm. This is an important feature to be aware of, particularly as a number of the investigations used in the diagnosis of Cushing syndrome rely on this. And its levels are highest between 8 and 9 a.m. So the morning levels are the highest. So they're both endogenous and exogenous causes of hypercortisolism. Exogenous causes are most common and contribute 80% of cases. Endogenous causes can be divided into ACTH dependent, such as Cushing's disease and ectopic ACTH secretion, and ACTH independent causes, including adrenal adenoma, adrenal carcinoma, and bilateral adrenal hyperplasia. So Cushing syndrome is defined as a collection of signs and symptoms due to persistently high levels of circulating glucocorticoids. Features include weight gain, hypertension, diabetes, osteoporosis, a number of metabolic irregularities can occur, menstrual disturbances, easy bruising, thin skin, proximal myopathy, and associated psychiatric disturbance. In particular, easy bruising, proximal myopathy, and osteoporosis are the most specific signs of Cushing syndrome. So this picture on the left, this lady, you can see she's got striae, she's overweight, She's got a very hirsute appearance with a moon face. And the figure on the right shows the wider signs of Cushing syndrome. So once you have found a patient and you suspect a diagnosis of Cushing syndrome, we then need to find out what the cause of the Cushing syndrome may be in these individuals. So first, we perform an overnight dexamethasone suppression test. Individuals are asked to take 1 milligram of dexamethasone at midnight, and then they come into outpatients clinic in the morning, and their cortisol level is measured. The cortisol, because they've taken the dexamethasone, should be suppressed. Having a very low cortisol level is normal. However, if it remains high at this point, then they have a further problem, and we need to investigate further. So next, a 48-hour dexamethasone suppression test or a midnight cortisol is performed. So the 48-hour test, so there's high dose and low dose tests. So a high dose test enables you to will suppress pituitary release of ACTH, and therefore cortisol levels will be low. So this will identify pituitary cause. So if this is suppressed, an MRI of the pituitary gland is usually performed. However, if the cortisol at this point is not suppressed, the next thing to perform is a plasma ACTH test. So this enables us to determine whether it's an ACTH dependent or an ACTH independent causes. If ACTH is undetectable, it's likely that something is secreting high levels of cortisol, and then this is having the negative feedback of this is inhibiting ACTH secretion completely. This is likely to be an adrenal tumour, and therefore CT or an MRI of the adrenals is further performed to possibly detect an adrenal adenoma or adrenal carcinoma. If ACTH remains detectable, we then look for something which is secreting the ACTH. This is usually an ectopic secretion, as we've mentioned before. The high-dose dexamethasone test would detect a pituitary cause. So therefore, we need to investigate for sources of this ectopic ACTH secretion, performing CT chest, abdo-pelvis, or MRI of the neck, thorax, and abdomen, really looking and investigating for this cause. So management of this depends on the underlying cause. So treatments include, for Cushing's disease, the main treatment is surgery to remove the tumour. If there's an adrenal adenoma, this depends if it's bilateral or unilateral. So unilateral adrenalectomy is performed if there's adrenal adenoma generally. A bilateral adrenalectomy is performed for bilateral adrenal hyperplasia. It's important to normalise cortisol levels with metyrapone, ketoconazole, or etomidate, because this can precipitate a crisis. A side effect of this is Nelson syndrome. This is quite an interesting syndrome. Once you remove the adrenal tumour, the pituitary continues to grow and grow because there's no downstream organ for the ACTH to act on any longer, so it induces hyperplasia of the pituitary. Adrenal carcinoma. So this is a very aggressive form of cancer or malignancy in most cases. And this is treated with surgery, radiotherapy, and adrenolitics agents. So ectopic ACTH secreting diseases are treated by looking for the underlying cause, which can be very difficult to find, and then surgical resection of the tumour if this is possible. If not, drugs that we've discussed above that inhibit steroid production are used to prevent cortisol action or cortisol production. So we'll now finish by discussing adrenal insufficiency. So adrenal insufficiency occurs when the adrenal glands fail to produce enough cortisol or aldosterone. So types include primary, which is the inability of the adrenal gland itself to produce hormones. This is accompanied by a high ACTH. There's secondary adrenal insufficiency, in which there's inadequate pituitary stimulation of the adrenal gland. This is accompanied by a low ACTH, and then tertiary, in which there's a problem with the hypothalamus. This is very rare. So causes of adrenal insufficiency include, so there's congenital causes, including congenital adrenal hyperplasia, and acquired causes of primary adrenal insufficiency, including Addison's disease and infection. A cause of acute primary adrenal insufficiency is Waterhouse-Friderichsen syndrome, which is bilateral infarction of the adrenal glands, most commonly secondary to meningococcal septicemia. So Addison's disease constitutes the majority of cases of primary adrenal insufficiency. It's due to autoimmune destruction of the adrenal gland, with 80% of patients have these antibodies against 21 hydroxylase. It also is predisposed in individuals that suffer from other autoimmune conditions, including type 1 diabetes, celiac disease, vertigo, hypothyroidism, and pernicious anemia. So Addison's disease can present both acutely and chronically. We'll discuss the acute presentation in more detail later. So chronic presentation, so the patient may complain of non-specific symptoms including malaise, fatigue, depression, anorexia, and nausea and vomiting, which have come on over quite a long period of time. There's gradual loss of lean muscle with progressive weakness and hyperpigmentation of the skin and mucous membranes. In particular, individuals present with hyperpigmentation of the buccal mucosa and of the palmar creases. This is because of high ACTH levels, which also stimulate melanocyte receptors. We stimulate melanocytes via the melanocyte receptor, There's this feeling of salt craving and fainting and feeling dizzy. This is due to a hypotensive state due to aldosterone deficiency. Features of other autoimmune diseases, including vertigo, may be present. So on this slide, you can see a picture of a lady who suffers from Addison's disease. So B is before treatment and C after. So in B, you can see the hyperpigmentation of the palmar creases, and in the large figure, you can see the very tanned appearance of this lady. Again, you can see vertigo in the hyperpigmented palmar crease, the hyperpigmentation of the buccal mucosa, and associated features of vertigo. Just to point out for sort of exam purposes, there's two conditions which sort of produce this hyperpigmentation that I'm aware of. So there's Addison's disease and Peutz-Jeghers disease. I would just have a look at both pictures, in particular before paper C, as they like to ask these in the third year examinations, or I like to ask you to distinguish between them. So investigations for Addison's disease. So in the acute sort of situation, you want to do a VVG. So another key exam question asked is that they often present with or often have a acid-base disturbance of a hyperkalemic metabolic acidosis. This is due to the lack of aldosterone action at the level of the renal tubule. They also have often hypoglycemic. Individuals have the 21 hydroxylase antibodies, and a random cortisol may be low. It's worth noting that measurement of the random cortisol isn't very effective and is just here for completeness. So dynamic tests include the short synactin tests. So individuals are given synthetic ACTH called tetraxoside, I think, and the test is positive if this fails to stimulate further cortisol secretion, because it shows that the adrenal glands are non-functioning. Non-dynamic tests include plasma ACTH, so low levels, also accompanied by a low cortisol level, suggest secondary or tertiary causes, and as discussed previously, a high ACTH level suggests a primary cause and primary cause of adrenal insufficiency, and plasma renin, which is also high due to a lack of aldosterone feedback. Other investigations include imaging, including chest x-rays, CT and MRI to look for TB, malignancy, and also other diseases. For example, you can have enlarged adrenal glands or diseases such as histoplasmosis, which can also cause acquired primary adrenal insufficiency. It's important to also test for thyroid hormone and autoimmune diseases. We pointed towards this earlier when we discussed hyperpituitarism, but this is because it's important to identify if the individual has thyroid deficiency, because we need to then replace cortisol beforehand if the two coexist. So management includes, so the mainstay of management is lifelong hydrocortisone therapy plus minus fludrocortisone replacement. So hydrocortisone is given in divided doses throughout the day to resemble physiological secretion. The last dose is usually given in the early evening because steroids can cause insomnia. Therefore, we don't want to give it too late at night. Fludrocortisone is given and titrated to sodium and the individual's blood pressure. Dosing depends with regards to fludrocortisone, and on days where the individual is doing exercise or excessive exercise, doses will be higher. Patient education is very important in the long-term management of Addison's disease. Patients should be aware of sick day rules to never miss their steroids. They should be made aware of increasing the dose to account for strenuous activity, and also what to do if they become ill or if they're vomiting. Patients are usually given a Medi alert bracelet and carry a steroid card to make individuals aware if they are found collapsed or something, that they suffer from adrenal insufficiency and need urgent medical attention. So we'll now finally discuss Addisonian crisis. This is acute adrenal failure. So individuals suffering from Addisonian crisis may present with hypovolemic shock, they're hypertensive, have a low-grade fever and maybe vomiting. It often presents with very severe abdominal pain, and because of that, this is a medical cause of an acute abdomen as well. Patients often in shock, so we've mentioned that before with the hypovolemia, so they may be tachycardic, have weak impulses and be tachypneic, and be very, very unwell with a reduced GCS also. So precipitants of this include infection, poor compliance with medication, surgery, trauma, and vomiting. So just to highlight with vomiting, that's why it's very important for us to give appropriate patient education and ensure that the patient knows that if they do vomit or have excessive vomiting, they need to take their hydrocortisone injection to avoid the precipitation of Addisonian crisis. So the immediate management requires 100 milligrams of IV dexamethasone, fluid resuscitation, and glucose. So glucose is not always required, and it depends if the individual is hypoglycemic. Individuals should be resuscitated according to, so there should be ATE management, and hypoglycemia should be treated with 50 mL of 50% dextrose. So that's the end of the presentation. I'm aware that there was a lot included in the, that covered a lot. If you have any questions, please feel free to email me. My email is provided below, but otherwise, best of luck with all of your exams.